We're here from India.
All right. Anyway, so let's start with this chest radiograph. So, you guys at NBI, anything to say? It's not. Sam, do you have anything to say?
Okay, so we have let's see, PA, chest radiograph.
Well, let me just compare one side to the other. What's abnormal here?
Normal, pleura. What's the topic of discussion?
Well, what do you think of the diaphragms?
Well, the left diaphragm is a bit more curved. Yeah, I mean the right, I suppose, is a bit more, is a bit flatter. It's not
Right,
exactly
so the right diaphragm looks higher than the left,
that too.
right? So the right diaphragm is elevated,
Yes.
or it looks that way.
A
So
little
is this diaphragmatic elevation or is this something else?
bit. Well, let's see about our position. Our position is actually rather good.
You said something about the left diaphragm looking a little more curved.
Yes, it does. It
Okay.
does look a bit more curved. The right does look flatter, which could explain.
So what do you suspect might be going on here?
We have the right diaphragm.
Anybody else?
Pleural fusion
Where?
at the right pleural base.
Okay, so what's the clue?
The lateral diaphragm is sort of, I don't want to say tented, but more flattened.
So the peak of the diaphragm is displaced laterally. All right, so if it looks like you have an elevated diaphragm, especially in an upright view, the fluid may be subpleural in location, layering underneath the diaphragm. And the clue for that is that the peak of the diaphragm looks like it's displaced laterally. So it looks like you have an elevated diaphragm with the peak displaced laterally. So the lateral view, what does that show you?
That just shows that you have the right pleural effusion. You have plasma spine.
So how do you know that's a pleural effusion?
Actually, that's a good point. I mean, you know what, maybe not pleural effusion. How about this? You have a positive spine side, but you have loss of the right hemidiaphragm.
Well, you have some clues here. I mean, it looks like there might be some suggestion of a meniscus sign here posteriorly. It also looks like maybe some of the fluid is extending into the fissure.
Yeah.
Okay, so that is a right pleural effusion confirmed here on the CT scan. So in an upright position, the fluid can go in the subpulmonic location, and so that can mimic an elevated diaphragm. So it's that displacement of the peak of the diaphragm that helps. Other things you could do if you suspect a pleural effusion, of course, lateral decubitus view. Remember, the blackness of the lung should go to the edge of the ribs. In the lateral decubitus view, we see this pleural opacity here. That represents the layering pleural effusion. Okay. So here's a patient who has pneumoperitoneum to show you where the diaphragm is, and there's also a right effusion, and it shows you how the peak of that diaphragm is displaced laterally if you have subpulmonic collection of pleural fluid. So we all know what pleural effusion looks like on CT. You get the diaphragm, fluid behind the diaphragm is pleural effusion, fluid anterior to that, adjacent to the liver, that's going to be ascites. Okay? So this case, who wants to discuss this?
There's a right with lung opacity with sort of a linear hyperdensity on the frontal image going through it. It's lower density on the frontal than it is on the lateral. Because of its close approximation to the minor fissure, this could represent fluid within the fissure.
What do you call that?
Pseudotumor?
Pseudotumor. Do you see the minor fissure on the lateral?
Yes. Just
Is that in the
anterior.
minor fissure?
I see the major fissure going down, but I think I also see the minor fissure horizontally. Just anterior.
Okay, so is that in the minor fissure? Is this in the minor fissure?
No.
So where is it?
In the major fissure?
Yeah. So loculated pleural collection's in the fissure. That's called a pseudotumor. It's in the minor fissure, but it could also be in the major fissure. Okay. You could tell with CT fluid attenuation, pretty easy. And when it goes away, as the pleural fluid goes away, often there's pleural fluid elsewhere also. So you might see some blunting of the costophrenic angle. So there's evidence that there is pleural effusion elsewhere also, if you're thinking about a pseudotumor. So these represent loculated collections of fluid. It can be in the major fissure, it can be in the minor fissure, almost always transudative effusions when we see this. So typically if it's in the minor fissure, it follows the contour of the fissure on the frontal and lateral view. You get this biconvex appearance on the frontal view as it is kind of loculated there within the minor fissure. And then that appearance here, when the fluid goes away, the tumor goes away. So that is a pseudotumor. Okay. If there's a question, it's easy to diagnose with CT. We just look for the location where it is in the fissure, and then you can look at the attenuation, and you can see that it's fluid attenuation. And as we've said, often there's pleural fluid elsewhere also when you have these loculated collections. So pleural effusions can be divided into transudates or exudates. Transudates, the pleura is normal. Exudates, the pleura is abnormal. So it allows then the fluid to have hyprotenaceous contents. So these are the criteria for differentiating transudative effusions from exudative effusions. Many etiologies for pleural effusions, right? So some of the more common ones, of course, heart failure, etc. Pneumonia, patient has pneumonia, you can have a parapneumonic effusion. It doesn't have to be empyema, but if there's a significant amount of fluid, you will be concerned about empyema. Here's another patient with pleural effusion who wants to talk about this case.
Sure. Okay, so we see on the right, there's a simple appearing fluid, but along the pleura, actually, once again, I'm looking at the liver. It doesn't look nodular or anything, but the pleura itself might be a bit nodular.
So what are you thinking about?
Well, could be pleural metastatic deposits with associated pleural effusion.
Okay, so when you have nodularity along the pleural surface and pleural thickening, you have to consider neoplasm, so malignant pleural effusion, right? So your differential for what could give you a malignant pleural effusion or pleural thickening, you mentioned metastatic disease from any tumor, right? Lung cancer or any tumor, breast cancer, etc., can metastasize to the pleura. Is there anything else that you might consider in your differential for this particular patient, if this is all you have, besides metastatic disease? Yeah, mesothelioma, so primary tumor of the pleura. So mesothelioma also look like this, and often we can't differentiate between mesothelioma and pleural metastases. Okay, so this is a malignant effusion, which is going to be mesothelioma versus metastatic disease, if that's all the imaging that you have. This particular patient wants to take a guess as to what's the cause of the pleural effusion for this person. First of all, if you had to get, do you think that's a transudate or an exudate? Yeah, it looks more complex. So what is it that makes you concerned about this being more of an exudative effusion? Loculated, right? These are adhesions. Also, the pleura itself is thickened, right? You have pleural thickening here. What do we think is going on in this patient?
Well, look at the liver. I mean, we have these hypoattenuating lesions here. Then maybe that's maybe four.
Well, what do we think this is?
Oh,
Gallbladder, what do you think that is? Pseudocyst of what? So what are you thinking about there? Pancreatitis, yeah. So this is a patient who has a cystic structure next to the pancreas, maybe a pancreatic pseudocyst. So acute pancreatitis can give you pleural effusions from irritation of the pleura, especially left-sided pleural effusions. So we can see that with acute pancreatitis, left-sided effusions. This one, not a mystery. There's a small pleural effusion. So in this case, it is from PE, right, pulmonary embolism. So PE can also be associated with pleural effusion. So we might see that also. Sam, you kept talking about the liver. Well, here you go.
Yes, yeah, that's terrible cirrhosis.
All right, so what's going on in this patient?
right-sided hydrothorax and the setting of cirrhosis.
So what do we call this? What's the term?
Just hydrothorax.
There's a term when there's liver disease, it's called, hydrothorax is just the non-specific term for pleural, right? Hepatic hydrothorax. So we see that quite a bit. Patients with cirrhosis, ascites, so these patients can also develop pleural effusions, especially on the right side. Whenever there's ascites, some of that fluid can get into the pleural space, especially on the right side from communications across the diaphragm. So pleural effusion associated with cirrhosis, we call that hepatic hydrothorax. Okay? What about this?
So there's near complete whiteout of the left lung with what appears to be left apical or left upper lobe. It's a kind of obscured by a rib, but that could be a whatever pulmonary opacity could be a lesion on the right. I'm also suspecting like a small trace right pleural effusion, right, customary blunting. And when we turn our attention to the CT, we see we're in an axial section of a CT abdomen pelvis, whatever CT pelvis, and we're looking at what is the uterus and several, I guess, heterogeneously attenuating lesions of the uterus.
So what are we thinking about here?
So, what am I thinking? And once again, exudative effusion secondary to metastatic disease.
So you could have, so if you have a pelvic mass associated with pleural effusion, right? It could be ovarian cancer with metastatic disease, that's certainly a possibility. Is there a particular syndrome that we're trying to get at here? What is that?
MEGS.
What is MEG syndrome?
It definitely has.
So what's the typical tumor?
Oh yeah, it's I know it's a theca cell.
So it's a benign tumor. So MEG syndrome here, that these patients can have benign tumors of the ovaries that can result in ascites there within the abdomen, and then that can also get up into the pleural space to give you a pleural effusion. So the typical tumors of benign tumor, ovarian fibroma or fibrothecoma. Although, of course, whenever you have a pelvic mass and a pleural effusion, you have to think about neoplasm, ovarian cancer, and malignant pleural effusions also. Okay? So this patient shows up in the ER with chest pain. You're on chest this week. What are you going to say?
So there's an opacity in the left lung, kind of around the left pleural surface. It looks also nodular. So I'd be concerned for like empyema or maybe some related collection.
Okay, so you think that this is a pleural lesion, right? Mm-hmm. So it looks like it's predominantly peripheral. It kind of has this lobulated appearance. So one possibility is it could be loculated pleural fluid. You might be thinking about underlying empyema. What else would you consider? Well, could it be cancer? Yeah. All right, so you could have cancer. You might have a mass with malignant pleural effusion. So what would you recommend to the ER?
CT.
That's all you're going to say, CT, or are you going to say something else? Of course, they'll wind up ordering a PE-CT, but yeah, so you want a routine CT with contrast, yes, right? You don't want a CT without contrast. Remember, the larger the abnormality, the more helpful it is to have contrast, right? So here's CT with contrast. So what do you think?
So kind of similar to what we were thinking. It looks like loculated pleural effusion. There's associated atelectasis. It's like multi-compartmental, some in the apex.
Yeah, why do you see these spikes along the surface of the lungs?
There's like adhesion?
Yeah, those are adhesions, right? So these are adhesions. There is some mild pleural thickening, right? And certainly not nodular or mass-like pleural thickening, but there is some mild pleural thickening. So the first thing on your list here might be what?
Like a parapneumonic effusion?
Well, there's some pleural thickening, though, and there are adhesions. So not just the simple parapneumonic effusion, but empyema, right? So be worried about empyema there. So typically empyema evolves in 3 stages: exudative, fibropurulent, organization stage. So you can get effusions next to pneumonia. In the beginning, they don't have to be empyema. And then if the patient is treated, the effusion will go away if it's not an empyema. Diagnostic thoracentesis recommended if the effusion layers at least 1 centimeter on the cubitus views in patients with pneumonia. In the fibropurulent stage, then you have bacteria and debris accumulating in the pleural space. If you do an ultrasound, you will see septations. The fluid starts to get more complex. Now you will see the decreased glucose and lower pH in the pleural fluid, increased white cells and LDH. In the organization stage, this is where the pleura starts to get thick. Fibroblasts grow into the exudate, so it's more of a chronic process. A pleural peel can form thick visceral pleural thickening. Visceral pleura can be thickened there. And in some cases, the empyema can drain spontaneously through the chest wall. That can happen especially with tuberculosis. That's called empyema necessitatis or empyema necessitans. Patients can also develop pleural fistulas, so air within the pleural space can be from bronchopleural fistula, it can be from drainage of the chest wall. If there are small amounts of air, of course, it can be air-forming bacteria. Okay. On CT for the empyema, we like to see a split pleura sign, loculated effusions with thickening of the enhancement and thickening along the visceral pleura. Here's a nice example here, some thickening along the visceral pleura, and also thickening along the parietal pleura. So that's the split pleura sign. So that means that the fluid is an exudate rather than a transudate. It doesn't always mean empyema. Sometimes malignant effusions can also give you a split pleura sign. But if there are signs of infection, and of course, empyema is the first thing that you're going to be thinking about. And the treatment is going to be, they'll treat with a chest tube. The patient may require decortication if it's more chronic in patients with empyema. So when you have these pleural collections, especially if there's air in it, let's say from a bronchopleural fistula, you might have an air fluid level, and you want to differentiate abscesses or parenchymal collections from pleural collections. So the shape can help. Pleural collections have a lenticular shape. Abscesses are round. Smooth wall, thick irregular wall from lung abscesses because you have necrosis of lung tissue. Uniformly enhancing wall may be non-uniform with lung abscesses. Empyema compresses the adjacent lung. This destroys lung. Obtuse angles with the chest wall, acute angles with the chest wall. Also, the size of the air fluid level between the different views. With an empyema, it will change because it's conforming to the shape of the pleural space. With a lung abscess, the length of that air fluid level tends to stay the same on the frontal and lateral view because this is a round collection within the lung parenchyma. So lung abscesses give you these round collections within the lung parenchyma. There are acute angles with the chest wall. There's necrosis of lung tissue. The walls tend to be thicker, as you see in this example, as opposed to empyema, more lenticular in shape. Thickened pleura, of course, helps you to localize that to the pleural space. Okay. So here's a patient who has empyema. We can see the pleural collection here. There's pleural thickening here, visceral pleural thickening, parietal pleural thickening, so you're not surprised. In this patient with empyema, patient gets a chest tube, and here's the appearance of the chest radiograph after the chest tube. So who wants to discuss this? Menachem, what do you think of this case?
So, seems like there is some sort of capacity still.
So if you're reading this chest radiograph, what are you going to say about it?
It seems like the fusion is gone from.
Well, we start with lines and tubes, right?
Right.
So what are you going to say?
So there's a chest tube in the lower right lung.
Right? This patient has a chest tube in place, right? For treatment of their empyema. Whenever there's a chest tube, by reflex, you also have to look for
Any pneumothorax.
okay, is there a pneumothorax? Anybody see a pneumothorax here?
Yeah.
Where?
Isn't it the right face? Am I wrong or?
So, are there any lung markings here?
I really don't see any.
No, and there are two
Other
chest
neighbor-
tubes, right? There's one chest tube here and there's one chest tube here.
Yes.
So here we have this lucency with no lung markings. So what do we think that represents?
Subpulmonic pneumothorax.
Well, it's not subpulmonic, it's a loculated pneumothorax there over the right costophrenic angle. Okay? Is that what you expect to see in this patient with two chest tubes?
Yes.
Yes, you would expect to see that?
It should be on suction, right?
Yeah. So,
The suction should take the air out.
okay, why isn't it?
It's trap lung.
How do you know this is trapped lung? Is there another finding on the plain film that helps you? What causes trapped lung?
Chronic fusion.
What is the problem that causes, so normally, if we have a pleural collection from empyema, right? So that causes the lung to collapse because the pleural fluid takes up the space. Then you put in a chest tube. You take out the fluid. You take out the fluid, the lung should re-expand to fill up that space again, right? That has not happened here, correct? So we think about trapped lung. But what is it that causes the lung to be trapped? Why doesn't the lung re-expand?
The visceral and parietal pleural are connected.
What's thickened? Is it the parietal pleural thickening that prevents the lung from expanding?
Visceral.
It's the visceral pleural thickening that prevents the lung from expanding. Okay? Is there evidence of visceral pleural thickening on the chest radiograph?
Yeah, it's, you see, what do I say? It's like the density, right? Increased density.
See this line right here,
Radiopacity.
right? That's the visceral pleura. That should be pencil line or pen line thick, right? It's very thin. That's what we look for when we see a pneumothorax. You look for that line of the visceral pleura. This is too thick. So there's visceral pleural thickening here. The lung's not re-expanding, so we're thinking then that this is a trapped lung. So this is a common problem, right? We can see this in anything that causes inflammation of the pleural surface. If the lung does not expand after drainage of collection, we think about a trapped lung. Okay? What's abnormal here?
Visceral pleural calcifications.
It could also be parietal, but I guess there's extensive pleural calcifications. What do you call this?
I'm not sure what you call it, but is it secondary to like a chronic empyema or something?
Well, chronic, yeah. If it's one-sided and asymmetric like this, you would think that this is probably from chronic empyema. Fibrothorax, right. There's extensive pleural scarring here. So the problem with this is that it's going to impair the function of the lung. It's going to prevent the lung from expanding normally. So that's a sign of a fibrothorax. So this can be, when we have extensive pleural calcification, this can be a complication of hemorrhagic effusion, can be a complication of pyogenic empyema, tuberculous effusion, asbestos pleurisy. All of these can result in pleural calcification and can result in fibrothorax. So when you have extensive pleural thickening like that, right, that can impair the function of the lung as this calcification and fibrosis really of the pleura around the lung prevents the lung from normally expanding with ventilation. Okay, so it can result in ventilatory impairment. So that's one of the complications of fibrothorax with extensive pleural calcification. There's a big mass here. Do we think this mass is pulmonary or extrapulmonary?
Pulmonary.
Why?
Is it like the angle that it forms with the pleura?
What's the angle?
It's acute.
Okay, so it looks like you have acute angles, right? So that suggests that you're dealing with the mass in the lung and not a mass from the pleural space. Also, where's the center of the mass, right? If you have to put the center of the mass here, right, that's actually located within the lung, so that can help you too. Right? So this is a parenchymal lung mass. What are things that we look for to differentiate pulmonary lesions from extrapulmonary lesions? Pulmonary lesions centered in the lung, acute angles with the chest wall, engulfs pulmonary vessels. We don't see vessels here. extrapulmonary lesions. On the chest radiograph, you can see what's called the incomplete border or disappearing border sign. So where the mass is in contact with the chest wall, the borders disappear. Medially, where it's in contact with the lung, the borders are well defined. Obtuse angles, displacement of vessels. So these are ways to differentiate pulmonary from extrapulmonary lesions. Right. Who wants to tackle this chest radiograph?
So, on the image on the left, there's a right mid-lung opacity with this loss of that lateral border.
And we call that the?
We just have it up. Is it this?
Yeah, how's your short-term memory?
Yeah.
When the border disappears, we call it the
Not silhouette sign.
disappearing border sign.
There you go.
Okay.
There you go. Yeah.
So there's a disappearing border sign. What does that suggest?
It's plural base.
Yeah, it's pleural base in contact with the pleural surface, right? So we have this now. What's your differential for this then?
The plural base mass.
Like, what's your differential? What could it be? Give me name some things this could be.
Like a plural met.
Metastatic lesion, right? Could be a metastatic lesion to the pleural. What else?
Could be.
What's your differential for a solitary lesion? Could it be lung cancer invading the pleural?
Yes.
Yeah, certainly. Could that be a pseudotumor? Could it be loculated fluid?
Yes. Yes.
Okay. You mentioned pleural metastases. What else could this be?
Primary pleural malignancy.
Like
Probably.
what?
Probably not. I mean, mesothelioma, but that would look a little bit.
Well, is this a good appearance for mesothelioma?
No, it's not.
Why not?
Mesothelioma would be sort of more widespread.
Yeah, so mesothelioma would be more widespread. In almost all cases, it's also associated with pleural effusion.
Mm-hmm.
So it's a more extensive tumor. Okay. There was a term called, it used to be called benign mesothelioma that should be in a differential for this. What tumor am I thinking about?
Solitary fibrous.
Yeah, solitary fibrous tumor, the pleura, right? They're not all benign, but this could be that, a solitary fibrous tumor of the pleura. Okay, so that's also in the differential. Is there anything else you might include in the differential? What do you want to see? What's the answer?
Oh, it's a lipoma.
This is a lipoma. This is the most common benign pleural neoplasm,
Mm.
or mass is a lipoma. These are very common, okay? So this one actually is extending through. You can see into the subcutaneous area. So that's a pleural lipoma, right? So these can occur. Most common benign pleural or chest wall tumor rises from subpleural adipose tissue, smooth, fatty, attenuated, easy diagnosis with CT. Not a mystery once you do the CT scan, but that is the differential when we have a lesion that we think is along the pleural surface. Nice disappearing border sign in that case, okay? Who wants to discuss this?
Opacity on the left subpleural region.
Okay,
That's more like, I guess, more like sessile shape compared to the fire study. So
what's your differential?
maybe a solitary fibrous tumor or loculated fusion or metastasis, primary lung cancer.
So one of the first things we want to think about is that, are there any signs of malignancy? What would you look for as signs for
Is
malignancy?
any like bone destruction?
Do you see bone destruction?
Maybe there's like a discontinuity of that rib over there.
So what could this be then?
Maybe a met.
Could be metastatic lesion. Anything else? So look carefully. You could see the rib here. You could see the rib here. This part of the rib is missing. See that? It's subtle, but those are the things you need to look for. So certainly metastatic lesion is in your differential here. Looks like it's pleural based. There it is, right? There is bone destruction. So besides, any tumor that can metastasize to bone, what else is in your differential for a lesion like this? What could this be? What other kind of cancer or neoplasm? Expansile lesion of a bone, especially a rib.
Myeloma.
Myeloma, right. This was myeloma. Okay. So if there's any bone destruction, look for, if you see a peripheral lesion, look carefully for bone destruction. Is that mass benign or malignant? Certainly it's large, you'd be concerned about malignancy, but is there any finding here that makes you more concerned about malignancy?
Isn't that again a posterior rib discontinuity there?
Well, let's see. Do you see this posterior rib?
Yeah, I can see that.
Do you see this posterior rib?
Yeah.
Do you see this posterior rib?
There in the middle there, I'm seeing.
I don't know. Do you see the cortex here?
Yeah, that's good.
Do you see the cortex here?
You know what, I'm getting faked out, yeah, that's fine.
Okay.
God, okay, so that's benign. Likely benign.
Does anybody see something else?
What about the anterior?
What about the anterior ribs?
Number 1, 2, 3, 4, 5 might be expanded anteriorly?
All right. Do you see this anterior rib?
Yes.
Yes. Do you see this anterior rib?
Yes.
Do you see this anterior rib?
No.
No.
Oh,
So we're used to very carefully looking at posterior ribs, but you also have to look at the anterior ribs, right? The anterior rib here is missing. That's another metastatic lesion. That's a big met to the anterior rib. Okay?
I feel that one.
So these are the things you look for on the chest radiograph when you're looking for bone destruction. Be careful of the anterior ribs. What about this case?
Looks like there's a rib fracture, or a few rib fractures,
Okay, so what are you thinking about?
like a hematoma.
Hematoma, right. So look carefully at the ribs here, right? It's pretty subtle, but there's a rib fracture here, see? There's discontinuity of that rib. Of course, you would get, in real life, you'd get sort of trauma and all that stuff, but so we have a pleural opacity associated with the rib fracture, so here you're going to be thinking about hematoma, right? So that's pleural hematoma associated with trauma and a rib fracture. So it's very important to look carefully at the bones because these can give you a clue as to what is going on. What is the asterisk marking in this case?
It's like a density level, like more posteriorly, like these.
So is that a hemothorax?
Looks like it,
Trauma patient?
yeah.
There's high attenuation stuff here, right? Is that a hemothorax or is that something else?
The other clues, yeah, I mean, it looks like a hemothorax.
Anybody have any other thoughts?
It's like the fat density.
So what do you make?
Like,
So what does that mean?
Huh.
That is displaced extrapleural fat. It means this represents what? Extrapleural hematoma. Will this be drained by a chest tube?
No.
No. The fact that it's convex in shape suggests what? Same thing in the brain,
Epidural, so like
which means
Subpleural, extrapleural.
arterial bleeding, right? Okay. So the fact that it is convex suggests that it might be arterial bleeding. So if the patient becomes unstable, if the H&H is dropping, the treatment then would be what? Embolization, because this could be bleeding from an intercostal artery. Okay? This is associated with rib fractures. It's not in the pleural space. Putting in a chest tube is not going to drain this because it will drain this part. That's just the pleural effusion. But that's an extrapleural hematoma. And then here on this coronal reconstruction, we can see it a little better. So the sign of an extrapleural hematoma is a displaced extrapleural fat. So this hematoma is not in the pleural space. It's outside the pleural space. These are associated with rib fractures. Okay? And it could, if it's convex towards the lung, it might indicate arterial bleeding. Right? So that's extrapleural hematoma. Intercostal artery, if it's anterior internal mammary artery, so we've covered that before. Another example, chest tubes here is not going to drain this. This is the displaced extrapleural fat. If it's convex, you think arterial bleeding. In this case, this might be venous bleeding. It's not convex, but again, there is displacement of the extrapleural fat. So that's an extrapleural hematoma. Okay. Why would anybody in a chest conference show you these two images? Well, the finding on the first image is pretty easy, right? What is that? Big,
Pleural mass.
there's a big mass. Might be pleural, might not be, a little hard to tell when they get this big. What's the finding on the second image?
Periosteal reaction.
There's periostic reaction, right? So what are you going to call this, given this finding?
Hypertrophic periosteal.
Yeah, hypertrophic pulmonary osteoarthropathy, right? You have something wrong, something in the lung associated with periosteal thickening in the long bone. So, what could this be?
Lung cancer.
So, lung cancer can be associated with HPO, right? So that can happen, right? The topic of this lecture is pleural disease. So, what pleural lesion is associated with HPO? Solitary fibrous tumor of the pleura. That can also be associated with hypertrophic osteoarthropathy, right? What are the findings here that tell you that this lesion is a fibrous tumor of the pleura?
But it's, on T2, it's kind of hypo-intense.
Most tumors on T2 are what?
Hyper-intense.
Are bright.
Yeah,
This tumor is
hypo,
dark,
yeah.
right? So what does that suggest?
Fibrous.
High fibrous content. Where else do you see this? What other part of the body?
Brain.
You see fibrous tumors in the brain?
Uh,
When you do MR of the uterus,
uh,
what do you see? What do fibroids look like?
oh yeah, they do look dark.
They're dark on T2, right? So tumors that have a high fibrous content are dark on T2, as opposed to most neoplasms, which are bright on T2. So the fact that this is dark on T2 suggests it has a high fibrous content. These do enhance with contrast, right? So they will enhance. Dark on T2, you think fibrous tumor.
Definitely.
Yeah.
Bright on T1 also characteristic of fibrous tumors?
They can be dark on T1 also. They can be dark on T1, but the T1 signal can be a little variable.
Okay. Is fibrin like a protein? Like fibrous content?
I think it has to do with the water content.
Okay.
That because it's fibrous, it has less water content, and so that's why it's not bright on T2.
Okay.
So fibrous pleural tumor, most interestingly, arise from the visceral pleura. They're not always benign. The larger they are, the more you would be concerned about malignancy, not related to asbestos. Okay? They are associated with hypertrophic osteoarthropathy. Interestingly, also associated with hypoglycemia. So a small percentage of these patients can have hypoglycemia. Those are the two syndromes that can be associated with fibrous pleural tumors. Okay? They can have calcifications, they can be pedunculated. The larger they are, the more you're going to be concerned about malignancy with these tumors. Here's a very large one that was growing along the diaphragmatic surface. So this one was actually easy to peel off, this particular patient. Sometimes, you can have tumors like this. So in addition to metastatic disease, fibrous pleural tumor, there's something else that also runs alongside the ribs. What is that?
Vein, artery, nerve.
Which of those?
The
You're gonna pick?
intercostal, like, vein, artery, nerve.
Which of those you're going to pick for this
Oh,
lesion?
nerve,
So what would this be?
like a neurofibroma.
Neurofibroma, right? So neurofibromas can arise from the intercostal nerve. So that might also give you, it looks like a pleural-based lesion. So that could also be your differential diagnosis. So that's our differential for solitary pleural lesions. This patient, what do we think is going on in this patient? What are the findings here? Well, the obvious finding is,
There's left pleural thickening and right pleural calcifications.
okay, right. So there's left pleural thickening with pleural effusion, and there's right. That's not the IVC, it's a non-contrast CT. That's pleural calcification. So your diagnosis is
Mesothelioma
no
or asbestos.
asbestos-related pleural disease. Right. So that can give you pleural thickening. It can give you pleural effusion. Certainly, You know, in somebody who has asbestos exposure, you want to make sure that you're not dealing with mesothelioma, but you can have pleural effusions and pleural thickening just associated with asbestos exposure. So these pleural plaques, this is also very common with asbestos exposure. So you can have this on-face appearance. Sometimes they look like leaves, they have a holly leaf sign, sometimes as when you look at these en face. What's concerning about this chest reading?
Well, the right base is completely opacified.
Yeah.
And as is like the lateral, middle, or whatever, upper lung as well.
Yeah. And does the right lung look small compared to the left?
Yeah, it does.
Okay, so what do you think's going on here?
I think that there's probably some underlying atelectasis, but from restriction of the, I mean, it could, I guess that could just be a very large pleural effusion. I mean, that's a possibility, that you have a large pleural effusion with passive atelectasis, but that doesn't feel right.
Anybody else have any other thoughts? So we have opacity here, right? We have some opacity here. You're worried about, is this the diaphragm or is that something else? And the lung looks small, right? So what are you worried about? You're worried about something encasing the lung, right? So what could that be? What is it?
Interesting. Okay, so that's actually, what is that, extrapulmonary, I mean, extrapleural, like heterogeneously attenuating lesion with, is it bony destruction?
Yeah, it's extending into the chest wall.
Yeah.
So what do you think this is? This is mesothelioma. All right. Also, it involves the mediastinal pleural surface. So whenever you have pleural thickening that extends to the mediastinal pleural surface, you have to be thinking about malignancies, metastatic disease, or mesothelioma. So when it looks like the lung is small and you have pleural opacities going around the lung is encased with tumor. Okay. So here you got to worry about malignant mesothelioma or metastatic disease to the pleura that's encasing the lung. What's going on in this patient? There's this opacity on the lateral view that's evaluated there with CT.
This kind of looks like round atelectasis.
Yeah, so what are the findings that tell you it's round
Is
atelectasis?
it called the galaxy sign? Or
No, it's not the galaxy
not the
sign.
galaxy,
It's a wrong TV show.
Yeah, something about space.
Spaceships.
Comet tail sign,
Yeah.
right? What else? So comet sign, the vessels rolling towards the lesion. What are the other findings associated with it? Pleural thickening is abnormal pleura. It's pleural based. It's an area of abnormal pleura, right? Comet tail sign, and look at the position of the major fissure. Why is it there? Volume loss. Those are the findings associated with round atelectasis. This can also be a manifestation of asbestos. So all of these things we can see with exposure to asbestos. The problem with asbestos is that there's these needle-like fibers that penetrate into the lung. They can penetrate into the lung parenchyma and all the way out into the space, and that's why you can get pleural lesions from exposure to asbestos also. It's fibrogenic, also carcinogenic. Right? Macrophages try to ingest them. Macrophages not release their fibrogenic enzymes, enzymes that become fibrogenic. That's why you can get scarring in the lung. You can get scarring in the pleural space from asbestos exposure. We can have benign asbestos-related effusions, right? You always need that history of exposure to asbestos, usually small, might be blood tinged, in which case you do worry about malignancy if you have that. But this was an example of benign effusion associated with asbestos exposure. You can have pleural thickening as a sequela of exposure to asbestos. You can have that too from exposure to asbestos. If the pleura, there are criteria for diffuse pleural thickening. If it's greater than 8 centimeters, Craniocaudate if it's greater than 5 centimeters wide, if it's greater than 3 centimeters thick, and this can cause impairment of lung function if we have diffuse pleural thickening. Pleural plaques, we talked about these. These tend to occur alongside the ribs, also along the diaphragmatic surfaces, so that's typical. So here's a nice drawing showing you where you get these pleural plaques. So these diaphragmatic pleural plaques calcification is very typical of exposure to asbestos and asbestos-related pleural disease. So these is what pleural plaques can look like on CT. So don't mistake these for lung lesions or metastatic disease. Those are just calcified pleural plaques. And on FOSS, you can see calcifications that look like that. Pleural calcification, we've gone through the differential of what can give you pleural calcification. Of course, exposure to asbestos can also do that. And then atelectasis. Pleural-based mass, abnormal pleural cocktail sign volume loss. That's what you look for to make the diagnosis of rounded atelectasis, although the common tail sign is very helpful when you see that, rounded atelectasis. Don't confuse the term asbestosis with pleural disease. Asbestosis is parenchymal fibrosis from asbestos exposure. You can have honeycombing, reticular opacities, etc., interstitial disease. But this is disease in the lung parenchyma, okay, from exposure to asbestos, not pleural disease. The most common neoplasm associated with asbestos exposure is bronchogenic cancer, right? Even though there is also increased risk for mesothelioma, the most common cancer is still bronchogenic carcinoma. But mesothelioma can also, of course, we can also get that with exposure to asbestos. Now, again, whenever there's mediastinal pleural involvement, always think malignancy. If you see mediastinal pleural thickening, especially if it's nodular. If it looks like there's encasement of the lung, that could be mesothelioma or metastatic disease to the pleural space. So we looked at these. Here is encasement of the lung with mediastinal involvement. Could be mesothelioma, but this was metastatic tumor. So we can't differentiate these based on appearance. Right? So both of these belong in your differential. This is colon cancer. Looks like mesothelioma. There's also liver metastases here, but that's metastatic colon cancer. Can invade, mesothelioma can grow through the chest wall. We've seen an example of that. Here's a patient with a large pleural effusion. But note, whenever there's pleural fluid, carefully at the pleura. If there's nodular pleural thickening, if there's pleural thickening involving the mediastinal pleural surface, you're worried about neoplasm. This was mesothelioma presenting as a large pleural effusion. Okay? More examples. This one has lymphadenopathy, invades the diaphragm. Differentiating benign from malignant pleural thickening. It's thicker, it's nodular, it's circumferential, involves the mediastinal pleura. These are the things that you look for to differentiate malignant pleural thickening from benign pleural thickening. Okay? Bear disease with lesions in the long bones, and this very funny looking infiltrative appearance around the kidneys. So this is like, no, it's not lymphoma. This is Erdheim-Chester. So I'll let you guys read about that in the handout, but if you come across that on the board exam, this perinephric thickening is very characteristic of Erdheim-Chester, but you also get long bone lesions with that. Okay. So this patient has multiple pleural lesions, right? But the clue to making the diagnosis on this case is there's no spleen, right? So what is this going to be? Splenosis, right. The lesions are only on the left side and the spleen is missing, right? So this is splenosis. So left side, and it enhances just like splenic tissue. This is splenic tissue that has gotten into the pleural space. So what happens here is there's trauma, spleen's ruptured, diaphragm's ruptured, splenic tissue gets into the pleural space, it grows, they do a splenectomy so the spleen is gone, but then later on down the line you will see these lesions in the pleural surface that enhance just like splenic tissue. The pathognomonic imaging exam for this is
RBC scan?
Yeah, RBC scan or liver scan. You look for activity along the of these nodules along the pleural surface when you're thinking about splenosis. Okay. This is a young woman. What are the findings here on the chest radiograph?
right midline portion of the right heavy diaphragm, there is a ovoid opacity.
Yeah, so there's this nodular opacity down there, right? And then when we look very carefully at the lung, what else do you notice?
Yeah, there's a notch.
There's what? There's a pneumothorax. So this patient has a pneumothorax and a nodule here. Assuming that you did not do a biopsy on this patient, what could this be?
Okay, so this is most likely trauma. That's
No history of
likely
trauma.
No history of trauma.
No history of trauma. It's a young woman.
I mean,
Especially if the
emphysema.
pneumothoraces are recurrent. What do you think about?
Okay, so
What'd you say? Endometriosis. So the term is catamenial pneumothorax. So these are endometrial implants that get into the pleural space. They could cause erosion of the visceral pleural surface, result in pneumothorax. So they can have pleural densities, which represents endometriosis, getting into the pleural space. So that is catamenial pneumothorax. Your differential for lesions with pneumothorax biopsy, metastatic osteosarcoma, that can also give you spontaneous pneumothorax. But in a young woman, catamenial pneumothorax. So usually on the right side, these lesions, these represents endometrial implants that gets into the pleural space in these patients. So about a third of recurrent spontaneous pneumothoraces in women of reproductive age, mostly on the right side, associated with endometriosis. They might have pain because of the endometrial implants eroding or irritating the pleural surfaces. Okay, and then here on VATS, these are what those lesions look like. So suppression of or elimination of endometrial implants with hormonal manipulation and resection and closure of diaphragmatic holes, because it's holes in the diaphragm that allow the endometrial implants to get into the pleural space in these patients. Okay. What is abnormal on this chest X-ray?
The left hemidiaphragm is elevated.
Yeah, now if there's elevation of the diaphragm, right, especially on one side, there are two major things that can cause that. What are the things we think about?
Phrenic nerve.
Yeah, so paralysis, right, of the phrenic nerve is one, and the other thing is just eventration of the diaphragm, where there's weakness of the diaphragm that allows it to elevate. How do you differentiate the two? Sniff test, right. So how does that work? So here's the CT showing you the elevated diaphragm, right? So with the sniff test under fluoroscopy, you ask the patient to take sniffs, right? And then you look under fluoroscopy. And what do you look for? Paradoxical motion. So notice the normal diaphragm is moving down, but the abnormal diaphragm is moving up. Okay, so if there's paralysis of the diaphragm, the abnormal diaphragm moves up. That's what you see with the sniff test. Okay? So, and on the lateral view, you can superimpose both diaphragms. So you can actually see the normal diaphragm going down and the abnormal diaphragm going up if you're doing fluoroscopy on the lateral view during the sniff test. You can also do this with ultrasound. You don't have to do it with fluoroscopy. You can do this also with ultrasound, and you can do it with dynamic MR too. You can do this with MR also. Have the patient take those rapid sniffs and then watch the diaphragm. Okay?